Hello, everybody. It is September 13th, 2021, and we are extraordinarily fortunate tonight to have Mayor Jenny Durkan with us to talk about her experience in the city of Seattle during the COVID pandemic. So I told her this was going to be the shortest introduction of her ever, because I was really hoping that she could start off with a little bit from talking to us a little bit about who she is and how she found herself as mayor of the great city of Seattle in January 2020. So Mayor Durkan, over to you.
Thanks so much. And first class, great to be here. I'm really sorry that we have to meet virtually. I give Professor Katz one free come back when we can all be in person, because I think these are lessons that need to be learned, and it's great to be able to get together to learn them. You know, I took a pretty circuitous route to becoming the mayor of Seattle. I went to undergrad at Notre Dame. Between Notre Dame and law school, I spent 2 years teaching high school English in a small remote Eskimo fishing village in Alaska. Decided I did want to go back to law school, spent some time practicing in Washington, D.C., came back to Seattle. I had mostly a criminal defense and civil litigation practice. And I always made time on the side to do a lot of civic work at the same time. I felt it was really important to stay connected with my community, and it really ran the gamut of things that I did on that. I then practiced for a number of years, and former President Obama asked me to serve as the United States Attorney for the Western District of Washington, which I did under him and Eric Holder, who was the Attorney General. And Attorney General Holder asked me to be on his advisory committee, which I did for the whole 5 years that I served as U.S. Attorney. So I spent about a week every 5 weeks in Washington, D.C., meeting with leadership from the Department of Justice and other governmental entities. And it was really, that was a great time. I'd previously been involved in and around government before. I'd had one previous role acting as counsel to the governor of the state of Washington. But it was a different viewpoint to be able to see across domains. And as U.S. Attorney, one of the things people don't realize, everyone thinks about the criminal prosecutions, but one of the other roles is you represent the U.S. government in all the civil and regulatory actions. And so you see across all spans of government, from veterans hospitals to the CDC to Department of Ecology, and it gives you a very different perspective. And then I went from that to practice law and was the global chair of an international law firm for a couple of years. And then the spot in Seattle opened up. Originally Seattle native, and Seattle at that time we thought was at a real crossroads, because it was the fastest growing city in America, had changed really rapidly. And with that change came some growing disparities, particularly among those who were very wealthy and those who weren't, between blue collar workers and the innovation economy, and between communities of color and others. And so one of the things that really motivated me to run for mayor was, how did we close those disparities so that the Seattle of the future could really be a city for all generations and all communities, and that we could close the gaps on the disparities. I will say that while I've always had an eclectic range of interests, none of those things in particular prepared me for what happened at the beginning of February of 2020, when we were the first epicenter of the pandemic. But that's kind of the route that I came to be mayor. A mayor, I will say unequivocally, I think mayors saved America during the pandemic. And I say that knowing we're not out of it yet, knowing that this administration is making some very bold and important steps on vaccinations and testing and the like. But in those early days, when there was so much happening at one time and so much conflict between states and at the national level, I believe that mayors were in a unique position to really unify among themselves. Because as mayor, it's one of the few jobs you can't afford to be partisan. You have to represent all of your residents and really be thinking about the health and safety of those residents. And it gives mayors the ability to communicate on those really important fundamental things to people's daily lives, and to see the impacts on the daily lives. And we're held accountable in ways that national leaders never are, because people see us in the grocery store, in the pharmacy, in the parks, walking And people have very little hesitation about walking up to their mayor and letting them know what they think on any range of issues. And so I think that that was the background of becoming mayor, and the job of mayors. One is really that closest official to the front lines of communities and seeing the impact of everything from wage disparities to labor protections to health protections. And then during the pandemic, how that impacted everything across the segment. So that's a little bit of a background. We've got some slides. We'll make these slides available for folks if they want them after the fact. Have no problem with doing that, and try to get through them and leave some time for question and answer. So Anthony, Rebecca, unless there's something else you want to touch upon, we'll jump right in. So as I said, Seattle was the first epicenter of the first confirmed cases and deaths attributed to COVID-19 in the US. I will always, you can go to the next slide, Anthony. I will always remember where I was when I got the call telling me that we had the first cases and first death in our region. I had been very worried about COVID-19 as mayor. Seattle has enormous connections with China and other Asian countries. We have business ties, trade ties, and a lot of tourism back and forth between the two. And so when we had the early warnings coming out of Wuhan, I convened my whole cabinet to do a tabletop exercise on what would we do if the pandemic came here. The head of my public health, who sat in my cabinet at the time, we dusted off our old H1N1 virus flu study. But her caution was, we don't think we have a problem. We think that we're on top of it, and we think that we have isolated the first cases and there's not community spread. We now know, of course, that that wasn't true. In Seattle, we knew at the beginning of this pandemic that once it was clear that there was greater community spread, and that means more cases than we knew because testing was such a problem, that we had to follow the science and we had to be data-based and health-based in our approach, that we could not take a political approach. And very early on, for example, we knew we had to follow the recommendations on the non-pharmaceutical interventions, NPIs, because at the time we didn't have a vaccine. Testing was very, very limited. Treatments were very, very limited. And so as we started looking at what we could do as a city and a region, we really had to look at those things we could trust. And that started with science and the non-pharmaceutical interventions. Next slide. The early modeling that we got was really dire predictions. And one of the things I think we'll talk about in the QA became very clear to me as a mayor that our health system, particularly our public health system, was really not equipped for a pandemic of this magnitude. And because of the things that the federal government lacked, it made it even worse, and particularly testing. We had no idea of what the real scope of the problem we were facing is because testing was so unavailable and limited. If we had made decisions based only on the number of positive tests, I think we would never have acted with the urgency that we did act with, that we're going to be talking about. Instead, I was very fortunate. Here in Seattle, we have a lot of strong public health and other health facilities, as well as research scientists. And very early on, within the first week, I was able to talk to some of those scientists about what they believed we were facing. They had done an experiment using a flu study here. They went back to that flu study and some of the original swabs to determine how many people in that had actually had COVID present, but had gone undiagnosed. Based on that, they did some early modeling, and the predictions were dire. I took notes in that first conversation I had. I'm going to hold them up. You won't see them here, but I do a little chart for myself because I'm sometimes number challenged. And at the time, we saw that the virus was duplicating in cases. Every 6 to 7 days, it would double. So I started with the week where we were and then doubled it and realized that if we did not take any steps, this was the beginning. For example, I learned on February 29th. So the first week of March, we're deciding what actions to take. And we determined based on the modeling that by April 19th, we'd have over 70,000 cases and thousands of deaths. We knew, for example, if we took no action by April 7th, there'd be 25,000 cases, 400 deaths, and that each one of the steps we took could try to reduce that amount by a certain amount. So I carried those charts with me on a regular basis because it was all about the human lives. We knew our healthcare facilities were not prepared. And so we had to take our actions to try to stop the virus in its tracks. Next slide. That quick action, I think, was really critical. One of the first things we knew is, I mean, it sounds really primitive and simplistic, but in order for the virus to spread, you have to have people-to-people contact. And so one of the greatest tools we had to lower transmission was to make sure people didn't come into contact with each other. And so working with our businesses and talking to our businesses, most of our major employers immediately went to a telework situation, so that the people were not traveling into work, they were not meeting in workplaces. We, the city of Seattle, were one of the larger employers. We also decided to go to mandatory telework. We worked with the governor and the county to do that. And rolling through that started first with telework and then limiting the number of gatherings it could have, closing schools, libraries, community centers. And then at the same time, always telling people and clearly announcing the reason why you were doing it and what the public health strategies and requirements that we wanted of people during those times. We also at the same time were scrambling because the virus is voracious and we were not quite sure how quickly we could get in front of the modeling by taking our actions. And I think if you go back in hindsight and compare what happened to Seattle and what happened to New York in terms of the trajectory of the virus, our early actions made a huge difference to protect our healthcare facilities. But we had to start taking a real cognizance of what happens if people get sick. And so setting up, for example, isolation and quarantine facilities for people experiencing homelessness or people who did not have a place to isolate or quarantine. Figuring out how you do isolation and quarantine in congregate settings like senior retirement centers, figuring out what the impacts, just the health impacts would be. And then if you shut down those works, what are the economic impacts on small businesses, on workers, on communities? All of that had to happen simultaneously and had to be really science-based, calculating out what the next ramification would be, because we were very much in the learning phase and went from setting up, for example, military hospitals to have to take overflow in hospitals if we got so many people sick. Next slide. The other thing we learned really quickly, and I would urge this, whatever you end up doing in your lives, one of the most important things you can know is what you don't know. And it was evident to me going into this that our public health local officials were overwhelmed by the size of the pandemic. And there was only so much bandwidth they were going to be able to have to pivot and to innovate and to look around corners. And so I was very fortunate. I decided I needed to have some base touching place experts to advise me on what I should be worried about, what questions I should be asking, and what the next risk should be that we needed to prepare for. That's how I met your Professor Katz. I was able to gather just a phenomenal group of experts from pandemic response, research scientists, public health experts, and met on a weekly basis just to do an assessment of here's where we are. What do I need to know? What are the questions we need to be doing? What are going to be the metrics we judge by what we have to do next and what steps we need to do and what's working and what's not working? That guidance was critical on each step that we did, because I think Seattle, we got a lot right. And the reason we got a lot right is we really were listening to people who were able to kind of analyze it from not just the crisis we are in today, but what the next natural iteration was going to be and how we prepared to lessen that. Next slide, please. One of the first things that was really important to us was testing. As I said, the CDC is well documented now, did not have adequate testing anywhere. And we knew without testing, we were really flying blind. We did not know for certain how many cases were in our community, where they were, and how we could both prevent and treat cases. So we were really behind the 8 ball. We decided that we needed to do a number of things to do that. I was at the time served as mayor on a group of international mayors that is a climate-based organization called C40. We created a separate entity that was really dealing with pandemic response and then recovery. And in that, I happened to serve on a panel with then the mayor of the largest city in South Korea that had really gotten testing and contact tracing right very early on in the pandemic. Through a long story, but we were finally able to acquire and purchase testing equipment or testing supplies rather from the government of South Korea so that we in Seattle could set up our own testing. We also knew that we would not be able to rely on just public health to do it. It was too big a scope. So we had a larger consortium where we had public health, our all of our hospital facilities, the State Department of Health, and we put to work our fire department because we saw very early on that our first responders, fire and police, were most likely to contract the virus or be exposed and then have to go into quarantine. And at that time, it was a 14-day quarantine, and we saw some cities in the region lose almost half of their firefighters and police just to being quarantined because of exposures. So testing was a real importance to us. So we first set up our own testing for first responders. Next slide. The widespread testing, yeah, right there, testing. So we first said, we saw a couple of things. One, first responders. So we had the first responders testing for first responders. And I was able to convince the state to certify our EMTs so that they could do testing. The first use of our testing was we did mobile testing to go into our senior homes because we saw that that's where the most vulnerable people were and where we saw the most clusters and outbreaks. At the time, because there was a lack of testing, the CDC guidance was to test only those people who had symptoms, who were showing symptoms. Well, I knew from talking to my advisors and experts that people would be sick and could transmit the virus before they were symptomatic. And so we thought it was very important to test everybody. So we did the first test of sending the fire department into when there was a facility here in the city of Seattle, a senior facility. We went in and tested everybody, every resident and every worker. We were then able to isolate and quarantine those people who tested positive and then went back in to do it again. And we found that that was the most effective way to stopping the transmission of virus in those facilities. And in fact, the CDC later wrote it up as a model to follow. We then had the fire department set up testing for first responders, as I said. And then they also created mobile teams to do residents. Next slide. Our next big step was we knew testing was going to be so critical for us to understand where the virus was, how quickly it was spreading, whether it was mutating, who had it, how did we get them in isolation and quarantine? And that was going to require mass testing. And nobody was stepping up to do it. So the city of Seattle decided I decided we would do it. And we acquired our own PPE and testing capability at scale. We opened free, low barrier drive-through and walk-up sites. We wanted to make it as easy as possible for people to get tested. And at the end of the day, more than 1 in 3 of our residents used our testing facilities at least once. So this testing was in addition to whatever was happening in hospitals, other workplaces, what public health was doing. But we really knew that for the city of Seattle that we had to have wide scale testing and we had to make it as easy and as low barrier as possible. So that meant free, quick, convenient. Next slide. As we said before, we had over 1 million Seattle residents and workers who tested using just our places. And as you watched when the COVID started to, as it ebbed and flowed, that testing was critical for us because we would be able to see the uptick and really devise our strategies and how to turn that dial on our strategies and where we were seeing the outbreaks. Because as we've seen over this pandemic, those outbreaks are not just always regional. Sometimes they are clustered within a particular community or geographic area. And so the strategy to attack that is different than if it's diffuse and throughout the region. Next slide. Some of the decisions we had that were driven by data and experts, for example, was working with the state and business to determine what are going to be the metrics we're going to use to let us know when it's safe to reopen and take off some of the stay-at-home measures. Because we closed down all of our businesses, all of our gatherings. And so how do we know when to turn the dial back? What are the things we look for to say, what's it safe to do when? So that was one of the really critical things driven by the data. Also, transmission is measured in case counts, hospitalizations, and deaths, because that really measures the impacts on community and also gives you the severity of what you're experiencing. If a lot of people get sick, but it's not serious sickness or doesn't result in hospitalizations or deaths, it demands a different response than if it is resulting in a lot of hospitalizations, serious sickness, and deaths. So we were really monitoring that. Also focused on what is our capacity at the hospitals, our testing, our PPE. Real tribute to the governor. He, incredible leadership in our state. He hired someone specifically to come in and work across all hospital systems in the state to create a dashboard so we could see where every hospital individually and regionally was in terms of its capacity, number of beds, ICUs, ventilators, PPE. And we'd be able to review that chart on a regular basis so that we would see if there were problems coming and be able to adjust for that. We also used data, skipping ahead a little bit, on vaccination rates. We knew as soon as we started talking about vaccinations, they were going to be the critical thing. And how many vaccinations were we going to need? Where were we going to get them? And what was our target goal for how many people had to be vaccinated? That was all going to be wound up in the data. Next slide. So we had a lot of published data. I know dashboards are the thing for government, and seems to be different dashboards, and everyone was putting up dashboards. John Hopkins has a great dashboard. CDC had a dashboard. Our state, our county, are this. It was one reason why we thought it really early on, it was important for us to agree on what were the metrics that mattered, so people knew what to look for, and also we knew what to look for. And so we really always tried to have a focus on what were those most important metrics, and how did we have that data so that the public could access it, but most importantly, so all the policy deciders, whether it's in the hospitals or at the State Department of Health level or mayors, could make the right decisions. Next slide. Once we got to vaccines, we knew that vaccines were going to be an incredible challenge for a number of reasons. Just the logistics alone, devising a system in place that we could do vaccinations for mass quantities, do it equitably, and do it in a way that, given some of the controls around these vaccinations in terms of temperature controls and how long they would last, have a system in place. It was probably one of the most significant logistical challenges the city's ever faced. And we were able to do it by making sure that we really worked across silos, not just across government silos, but with our hospitals and public health, with our community-based organizations, to figure out how do we get vaccination systems in place that can reach the critical number of people, but then also do it equitably. Because we knew that the communities of color were most impacted by COVID, both by the health impacts and the economic impacts. We had to devise a vaccination system that didn't reflect those kinds of inequities. And so this required a real multimodal type of approach. Federal government went with mostly a pharmacy approach and hospital approach. We really focused on pop-up clinics, a few max clinics, and then working with our community-based organizations, and particularly in our communities of color, getting vaccination pop-ups for our BIPOC communities. Next slide. And at each stage of the way, and I'm sure all of you have realized this, that maybe Rebecca, Professor Katz knew, but I don't think many of us policymakers knew in February of 2020 that we would still be as challenged as we are by COVID-19 near the end of 21. And so having a system in place was critical to have data that we could look at to figure out what's the next stage, and then how do we get ahead of this virus. And part of this, right, I just want to make really clear, I'm talking about here in the United States and our communities. A whole nother class could be devoted to what do we do to make sure that the rest of the world can equitably get access to vaccination, let alone all those other things that go with the response to COVID and the economic response as well. But here we've really been looking at how do we make sure that as we get to the next stage, we're ready for it, so our city can really progress through and succeed as much as possible in this. So we have mandated vaccines for employees and businesses. We've been tracking the new variants, and we've been really trying to adapt what our approach is based on the science reality of what is this virus doing. Next slide. 1 year into COVID, I can say that there was a review done by New York Times that said that if other cities had taken an approach similar to Seattle's, we would have had significantly fewer deaths in America. And I think that it showed that that data-driven approach, speak with one voice across government, don't be partisan, but base it on the health and science, clearly communicate to the public what it is you expect from them to do, and be honest, always honest about what you don't know and how things are likely to progress. Never overpromise. This pandemic has, I think, proven us wrong every time that we've been hopeful that we've been closer to the end. Next slide. And 19 months later, I'm happy to say that Seattle has the lowest number of confirmed cases, hospitalizations, and deaths of any city in the United States. And that is consistent with the widespread testing that we did early to identify where the outbreaks were and what we could do to mitigate against those outbreaks. Next slide. Lessons learned for preparing for the next pandemic. Obviously, we have to have a better national response, both in terms of what the health response is going to be and things like the supply chain. In the very early months, it was like the Hunger Games. You had cities outbidding other cities just to get masks or gowns. It was like a scavenger hunt for testing supplies. People were pitted against each other, trying to get everything from, supplies for their healthcare workers to respirators to, you name it. So I think that the next national response has to be not only how do we detect and fight it, but what does that supply chain look like? State and local jurisdictions have to have from the outside access to funding, infrastructure, policy, technology, and the data systems, because they are the front lines. The health of America is made or broken at the local level. There has to be better data and forecasting. I'm very excited that one of the experts that advise me weekly is now at the CDC setting that up nationally, which is, I think, will make a huge difference. Equity has to be a huge focus, both because it's the right thing to do from a justice standpoint, but it's also the right thing to do from a public health standpoint. We know that we also have to have better connectivity between public health officials, elected leaders at all levels. Public health's pipe just wasn't big enough for this event. And they were used to dealing with very different types of science-based decisions that don't take into effect a lot of the other policy decisions that have to be made when you have something the scope of this pandemic. Across the board, we had to pivot basic city services. Give you an example, the kind of policy decisions you have to make. City of Seattle has a range of human services funding that it gives for communities. we have one of our largest entities is for our aging population, but a lot of those services, including the nutrition services, were structured and funded through a series of senior community centers where seniors could gather for education, for meals, for community, etc. Well, all of those were closed down. What do you do then to those seniors that relied on that community center for their food? We had to almost overnight stand up a hot meal delivery system for those same seniors. We had kids who were used to getting their food at schools, and the free and reduced lunch population was a really important part of the nutrition. When schools closed, what happens to those kids for their nutrition? What happens, because we also do nurses and doctors through the school systems when they're cut off through that healthcare? When you have thousands of employees lose their jobs simultaneously, what do you do in terms of not just unemployment, but what other services are available that will fill a gap before that unemployment comes? And so across the board, almost every line of business the city has had to pivot and innovate itself on how to serve the public. And we had to pivot and innovate in terms of how we did it with, so many of our workers suddenly working in telecommuting, change how people could get their work from their government. So having a real structure in place and preparing for that, I think, is important. And then local operational partners, whether they're hospitals, fire departments, CBOs, they are the ones that can bring it to ground quickly. Government's pretty lumbering. Federal government's the most lumbering, state government the next, local government, we're a lot more agile, but even we are not as agile as if we can employ those people who are closest to communities, whether it's community-based organization or a hospital or system of doctors. So those are some of the lessons we've learned, is that number one, the other thing I will say is 100% of the time you have to communicate clearly to the public, and you have to be able to communicate the truth as you know it. We found in the city of Seattle that every time we asked people to step up to do something, they did. And we have very successful, over 83% of our residences are now vaccinated or started their vaccination, 12 and older. And so, but at the same time, if you're not clear in your messaging, that's when you start to get the resistance, and people, their distrust of government or systems kicks in. And this has been an event of such a long duration that basic trust and knowing who can be trusted was really important at the start. We knew that public health was going to be trusted more than some elected officials, so they had to be the people carrying the message. We knew some community-based organizations or community leaders were going to be trusted more than public health, because there's generational distrust of the healthcare system in some communities. And so you had to be willing to surrender. It's not about control. It really is about effectively getting out both the message, but then the treatments, the vaccines, and the like. And you can only do that if there is a highly collaborative structure in place. Silos will kill you every time. Turf will kill you every time. But having unified goals, objectives, and metrics, as well as willingness to really share information, I think is the thing that's going to be critical for the next pandemic. Next slide. And now I think that sets us some time for Q&A.